today's case study, carrying on our CNS theme. Today's video revolves around anxiety. Okay, let's start. One of your regular patients, 45-year-old Mrs. Anxiety, enters the pharmacy. Mrs. Anxiety tells you she has recently been getting really anxious and is also getting quite congested, which she knows is due to a cold she picked up a few days ago. As a result, she went to see her GP to give her something for her problems. She also asked to buy her usual packet of Pharmasimple for her migraine, which you know the GP already is aware of. Identify the 2 drug therapy problems present. Now, screening the prescription, our first drug therapy problem is the risk of prolonging what is known as the QT interval. Now, you're probably wondering what this is. Well, the QT interval stems from us taking a look at what's called an electrocardiogram or an ECG. Now, this looks at electrical potential measured off the heart, and if I draw a quick ECG, so this is a normal ECG. You have the P wave, QRS complex, and T wave. And sometimes there's a U wave, but sometimes there isn't. But these are the main components. Now, the QT interval is measured on the ECG from the start of the QRS complex until the end of the T wave. That is the QT interval. Now, usually the QT interval represents depolarization and repolarization of the ventricles. The ventricles being these lower chambers that normally eject blood out of the heart, say through the aorta and so forth, or to the lungs. Now, another way to look at it is contraction and relaxation of the ventricle, since this is what it's reflecting or showing us. Now, if the ion channels of the myocardium malfunction, most commonly due to delayed potassium rectifier channels or HERG channels, so this is looking in terms of prolonged QT interval, then this may lead to a decreased potassium efflux. Remember, potassium normally goes from inside to outside the cell, so it's normally an intracellular ion. Now, what this is going to do is it's going to lead to a surplus of positively charged ions because you've got so much potassium inside, and it's going to extend this repolarization. A repolarization normally are relaxations, normally when, say for example, potassium channels, you have potassium leaving the cell, so it becomes less positive inside. Because of all that potassium leaving, it leads to a less positive charge inside, and that's known as repolarization. It's normally reflective of relaxation on the ECG. Now, obviously, if there's a decreased efflux of potassium, for instance, that's going to lead to more positivity inside the cell because there's going to be more potassium, and this is going to extend that repolarization phase, and so we're going to get a prolonged QT interval. Now, this can actually cause arrhythmias such as torsade de pointes. Torsade de pointes is French for twisting of the points, and how it occurs on the ECG. It looks like it's twisting of the points on the ECG. And this is a potentially life-threatening ventricular arrhythmia or ventricular fibrillation. Now, it can actually lead to delayed contraction of the ventricle, which can lead to a reduced cardiac output and so forth, and can even lead to sudden cardiac death, like when you see someone go into a cardiac arrest where it's pulseless. Now, the new drug given to the patient for anxiety, the escitalopram, this antidepressant, known as a selective serotonin reuptake inhibitor, is known to prolong the QT interval due to its effect on potassium HERG channels. Now, the patient already has risk factors for prolonging the QT interval, and this is mainly due to the medication they're taking. For instance, the patient takes domperidone. Now, this is an antiemetic that they're using in this case for migraine. It's a prokinetic agent, and it actually has the risk of prolonging the QT interval, and that's due to its effect on potassium hag channels. Now, the patient is also taking a diuretic, a thiazide-like diuretic, indapamide in this case, and that has the risk of causing hypokalemia. Now, this is having low potassium again. That may cause a surplus of positivity inside and may extend the repolarization if the hypokalemia occurs, and so puts the patient at risk of prolonging the QT interval if this occurs, this hypokalemia. So we can see there's this compounding risk, and it may be wise to flag up to the prescriber these risks and potentially suggest an alternative. One option may be to try an alternative antidepressant from the same class, SSRIs, but one that doesn't possess that prolongation QT interval property. One that's quite commonly given is sertraline. It has very few interactions and it doesn't cause that prolonged QT interval that we don't want to take any risk with in this patient. So that's our first drug therapy problem, and that's what we could do to resolve it. Now, our second drug therapy problem, if we look at the prescription, is that the patient has been given pseudoephedrine, which is a sympathomimetic agent. Now, pseudoephedrine acts to instigate the effects of the sympathetic nervous system by acting as a sympathomimetic, and this may lead to certain things such as vasoconstriction, and obviously the sympathetic nervous system mainly intertwining with our cardiovascular system. Vasoconstriction is something that you may see during this fight or flight response by binding to adrenergic receptors found in the body, such as alpha and beta receptors to some extent, and in the nasal areas, vasoconstriction. So this is how it works to help the patient. By vasoconstricting nasal passages, it may actually help to shrink the swollen nasal vessels and help reduce congestion to some extent, amongst other mechanisms. Now, coming back, remember, blood pressure is equal to cardiac output, which is the total volume of blood pumped out of the heart per minute, which is made up of stroke volume, total amount of blood pumped out of the heart per beat times heart rate, which is beats per minute, times peripheral vascular resistance. And obviously this vasoconstriction phenomenon that may occur is obviously going to increase peripheral vascular resistance, which is usually the resistance to flow, typically affected by internal vessel diameter. So an increase in peripheral vascular resistance through vasoconstriction may thus increase blood pressure, and so this may actually act to worsen Mrs. Anxiety's blood pressure control. Remember, Mrs. Anxiety is actually taking antihypertensives such as amlodipine and indapamide, so increasing blood pressure is going to worsen the blood pressure control, and this is something that we want to avoid. Thus, this should be flagged up with the prescriber, and we should just let them know of this issue, and maybe in the meantime they can try other non-pharmacological options. So this may be steam inhalation, possibly using certain aromatic oils like menthol crystals, for instance, and making sure that she's careful not to scald herself, potentially may use certain saline sprays, or there's different options that can be tried that could ensure that the patient's blood pressure is not increased. Now, with both drug therapy problems identified, let's move on to the patient query portion. The question reads, Mrs. Anxiety returns to the pharmacy, informing you her migraines are a bit more frequent. She asks if she could purchase some cocodamol since it helped her brother's headache recently. Now remember, in patients with migraine, there tends to be what's called reduced gastric emptying. So this is to do with the gastrointestinal area of the stomach. If there's reduced gastric emptying, this actually explains why in some migraine patients, a lot of them may get nausea or emesis, or even vomiting potentially. And there's also going to be an increase in intestinal transit time, so it takes longer to empty. Now, you also should remember that this physiological phenomenon may also occur in patients with migraine that don't suffer from nausea. Knowing this, it might not actually be a good idea to give a codeine-based product, such as that seen in cocodamol, which is made of paracetamol and codeine. The reason for this is it can delay gastric emptying and increase intestinal transit time further. Now, a codeine-based product does this by binding to opioid receptors, in particular mu, in the submucosal or myenteric plexus, activating nerves potentially in the bowel to reduce peristalsis. Now, what you should do is we should check with the patient how frequently she's suffering from migraines, and potentially how often they're using the analgesic, the paracetamol, as this may trigger referral. For example, do they fit in the category for potentially preventative treatment, or are they suffering a medication overuse headache? So it's just things to put in the back of your mind. Also, it might be a good idea to tell them to keep a diary for triggers if they haven't done so already. Now, in this scenario, it may be an option to discuss potentially maybe a 5-HT1 agonist, such as sumatriptan. And normally during the headache phase, in a patient with suffering a migraine, there's normally vasodilation, and under the vascular theory, they say that increased flow is what leads to the headache. And so, constricting, so causing vasoconstriction of those extracerebral arteries, and that reduced flow may help, stop a headache and cause a resolution of the headache phase. And so you may give a 5-HT1 agonist and tell the patient to take it when they do get a headache. An example of that's a triptan, like sumatriptan. Now, these are just a few options that can be discussed. Now, that wraps up today's case study. If you found today's video helpful, please give it a thumbs up, and don't forget to subscribe to the channel, making sure you hit the bell icon, of course, to keep updated on new videos.